Hello.
Hello, Assalamu alaikum. My name is Shabir
Michael.
Musa. I am the family physician for Johannesburg, also the president of Wonka Africa and facilitator for Afro-PHC. We have this webinar, Assalamu alaikum to all our Muslim listeners and those who've joined us. We are basically focusing this webinar today as our weekly webinars at a slightly later time to accommodate a panel of people led by Riyas Fadal. And he's leading a group of Muslim doctors in Johannesburg. We're looking at what goes on in Johannesburg in the private sector as an opportunity to understand what are different primary health care responses across Africa. So this is a webinar series, welcome to it. I'm going to basically just introduce briefly the panel and we will go through in a conversation through that. I just want to show you briefly, if you're not familiar with Zoom, how you go through it. So just give me 2 secs. If you can basically hover your screen and you'll see your settings. As you do that, you should be able to pick up your audio settings. So you see the sort of settings at the top, and you can choose your audio settings and fix that up. You can also turn to the Q&A. So please put your questions into that that space at the bottom. And also the chat, if you click on it, you'll get that on your right-hand side and be able to see where you can chat, what's happening in the chat, and add to chat. But please use the Q&A for questions as you're going along. And lastly, you can raise your hand and lower it if you wish to speak. We can allow that as you're going along, just depending on the number of participants and how manageable that is. So put it up and we'll see. But please put your questions into the group and we go from there. So thank you very much. I think I'm sharing profile of Africa, but it's a week dated, but you know, things are very much the same. With South Africa leading the pack in Africa in terms of COVID disease. And I think that it's a sort of strongly upward curving graph. And I think we need to be aware of the fact that whilst the rest of the world looks overwhelmed, Africa is soon to be overwhelmed as we proceed. I think the South African profile looks quite exponential in terms of this. This is although a week-long old data. The pictures look much the same. I've shared this last week briefly, as well as the deaths that are showing up as from natural causes over 60 from a MRC report on the 23rd or the 1st of July showed this kind of pattern. And when we look at it more closely, it looks like Johannesburg's quite in the middle of that setting. So let me just introduce the panelists, and I think they'll come on board. If you can just open your videos. We have today Riyas Fadal, who'll share a little bit about his background shortly. Shoyab Wadee, who's a renal physician. Essack Mitha, GP and working clinical research. And then Fathima Lambat, who's joined us, and you can probably see a picture soon, who's an intensivist in Indonesia, in Johannesburg, and then Fathima Minty-Seedat, who's a GP and all involved. So all of these great people are doing some wonderful work on the ground in the private sector. And I think that we've been looking a lot at family physicians functioning in the public service, but I've had very little of an insight in what's going on in the private. So we're really happy to have the group, and I'm sure that each of you, when you have the opportunity to speak, will share a little bit more about yourself than I have. But perhaps let's start with Riyas. Riyas, I've been part of this group, and you've kind of reached out saying, why don't you join this group of doctors, Muslim doctors in Johannesburg? Tell us more about that group and what's the story with the group.
Thank you very much, Prof. Musa. We appreciate this opportunity. We're honored by your invitation to share some of our experiences. I'm extremely humbled by the participants in today's webinar. I'm a general practitioner working in the Bruma area, but I have a portfolio of responsibilities, which includes working for Life Healthcare and responsible for the renal, mental health, and rehabilitation business. I hold a few board directorships at hospital level and have a significant responsibility in the private health medical scheme environment with prescribed minimum benefit designs and Council of Medical Schemes. Being a general practitioner in this environment and of just being a clinician with all of our colleagues in the nurses and allied health professionals, it's an extremely overwhelming environment that we're in. But we give thanks to God Almighty and our colleagues for their strength and their comfort. And in March, when we started seeing the first cases, we always had a group, the Johannesburg Muslim, or the IMA, the Islamic Medical Association group, a WhatsApp platform where we would engage with specialists on that platform, specialists and GPs. We'd pose a question on that platform and we'd get answers. And in March, when we started seeing COVID, I think it was panic. It was panic for all of us because we were overwhelmed with social media. We were overwhelmed with the reports coming out of Italy. And we had this sense of fear that this could be our reality and it could be our reality overnight. And we thank our president and his ministers for buying us some time. And we thank God Almighty for giving us some time with the lockdown. We know that there's always controversy and there'll always be a left and a right or a middle road. The reality is we needed time to consolidate. I think at the time as well, when there was this overwhelming panic, because we all understand the issues with our health system. We all, in any country, you're going to have a resource restraint when it comes to any health system. And in our country, with the Gini coefficient as it is, even though we work in the private sector, with the majority medical funded environment, we have a large patient base who are self-funded, which are people that are paying out of their pocket. And we have a large base of people that are unemployed, that we provide services to. So we don't just only provide a private service, but it's also to the community at large. In March, there was pandemonium, there was panic, and we had a WhatsApp group, and we could see some of the chatter coming through this WhatsApp group. It's an amazing platform. From the first week or first few days of that WhatsApp platform, the chatter was inundating the group, and it was decided by our colleagues here that we should create a few groups, another group, and we could call it the IMA COVID group. We then went on to create the IMA COVID group, which got filled the first day with colleagues, and it was Muslim and non-Muslim. It was open to everyone. It was just so that we can provide support to each other. And then we had a second group, and then we have a third group, the farmer group. We've got a physiotherapy group. And these groups were set up so that we can, and I'm again grateful to our colleagues here and all of our other colleagues that are not here, and grateful to the Islamic Medical Association for all of the specialists that are there that provided the oversight. Professor Anwar as well. All of the specialists, yourself, Prof. Mahdi, all of the specialists that came in and provided their time to answer questions. And sometimes they answer the same question over and over again.
If I may stop you there, Riyas, just to focus you a bit, what has been the response or the reaction from GPs? What has been their challenges dealing with COVID?
So
briefly.
Firstly, it was a lack of understanding and a lack of knowledge in March. But through the chat and the discussions and through NICD's guidelines, and obviously through the colleagues on the group, we set about to write up guidelines as best as we could. And we use those guidelines to help us in patient engagement. So currently, as a general practitioner, we're facing numerous patients. We're facing large amounts of patients that are coming to us via different channels. We have some that have gone via call center that have been diagnosed as COVID positive, but nothing else after that. So we're picking them up in the middle of the treatment. We inundated with winter and coughs and flus. And those are and a larger proportion of those are COVID positive. We inundated with corporate employees who don't know what to do and how to manage. We receive phone calls daily from employers saying, we're in utter panic. One person has tested positive. What do we do? So general practitioner, we also now taking lots of telephone calls from patients who are afraid to come in.
Right.
We're seeing mild patients who are asymptomatic patients that were diagnosed on screening. We're seeing mild patients with very little symptoms. We're also now seeing moderate and severe patients, and we're getting a lot of patients.
Sicker.
Yeah, and we're getting a lot of patients that need to go to hospital.
Yeah. So at the beginning, I think about 2 or 3 months ago, we had done something around helping GPs prepare by a guideline very similar to the one in Johannesburg that the public service is using, which kind of detailed how doctors should manage the risk of patients presenting at the practice. But things have moved on. Obviously, hopefully doctors have actually taken that on board in terms of infection protection control in their practices, given what you've said, that they've had to reorient their practices a little bit. But as time has moved on, you're getting sicker patients coming in. How are they managing that? And some practices have actually closed up or found their volumes less. I'm not sure whether you're speaking to yourself or as a general rule in the practice in the general private general practice in Johannesburg at least. What is your impression of them coping with both the fact that some of them may be seeing fewer patients and also that they're seeing sicker patients?
Oh, we're on various groups and we get different chatter. And you're right, some practices are quiet. I think a lot of general practitioners in the who have high risk themselves are wanting to see less patients. I think there's also a fear of themselves. We have lost colleagues, and may God grant them the highest stages of paradise.
Sure.
A lot of doctors now, we used March and April to prepare for this onslaught because we knew a time was going to come when every patient is potentially going to be positive. Talking personally from my practice, we've now set up a special respiratory area for COVID, for moderate and severe COVID, working with physiotherapists. I think they're the unsung heroes of this disease. They help patients give us significant feedback that they're helping relieve a lot of that congestion on the chest. And I think our practice number, patient to GP or patient to doctor numbers are going to be completely overwhelming. So the team management of patients are going to be much more critical.
It's critical.
We're going to
of course.
How to put community members in place. We're going to have to think about how to empower previously infected patients to help counsel the current infected patients.
Of course. Well, lots of great ideas. Let's move to Shoyab. Shoyab, being a specialist in physician, lots of GPs are sitting with the challenge. I'm getting these very sick patients. What would you suggest as ways in which they can manage? And they're sitting with this challenge where not only is the public hospital closing very frequently, but private sector hospitals are closing. And you sitting there, and what would your advice be to a GP? What does he need to do in managing that patient that he's struggling to get into a hospital?
So I think, thanks, Shabir, thanks for the opportunity. I think one of the problems we have with COVID-19 and the current problems is that obviously it's rapidly evolving and things change. So whereas there may have been hospital beds available last week, the number of hospital beds available is declining day by day. And a week or two time, there may not be any hospital beds which are available. So the paradigm keeps shifting. And obviously, as a general practitioner, you've got some idea in your head as to who needs admission, because there's a few questions you're asking yourself on a daily basis. The patient rocks up. The first question is you want to advise the patient what to do in terms of isolation. Obviously, those are issues which GPs are very well versed on. And obviously, you'll have to visualize them, where they live, who they live with. Is it an elderly person? Is it just their spouse? Who else is positive in the household? So all those questions, GPs are really the experts at that, for example. They do that.
And they've been doing it for the last 3 months. And like you say, that's the way they've been doing, but now things are changing.
But now things are changing there as well, because often 3 or 4 people in the house are positive and one person is negative. So it becomes a harder thing to manage. The second question the GP is asking themselves is, who can I treat at home and who needs to go to hospital? Obviously, when hospital beds were easy to come by, that was a much easier decision. If you look at the NICD criteria that they put out like in March, April already, in terms of who can be safely treated at home, those with no respiratory distress, with no confusion, with a low pulse rate, with minimal symptoms, with a saturation which is above 93% or 94%. But many of those patients may not be able to access hospital with time. So we're reaching a paradigm where, as a GP, you're going to have to sort of use further tools to decide, is this patient someone who will be able to manage at home? Or is this someone who's going to definitely worsen and going to need a hospital bed? And we should start looking for a hospital bed now, because as you know, it can take 24 hours or more to find a hospital bed. So I think those are the questions. And I think that has changed. So I think as a GP, you really need to start looking at predictive factors like, so you don't necessarily have the patient to be in respiratory distress, but they've got significant comorbidities. If they already have a tachycardia and the saturation is a bit low, you may not need to wait for them to be desaturating. You can start looking for a hospital bed already. At the same time, for some of those patients, you may want to do additional tests. So, for example, if you're not sure, you may want to do some blood tests. A very high CRP, for example, may predict the need for admission. A very high LDH may predict the need for admission. A very high D-dimer may predict the need for admission.
And we could get that in the private sector quickly, the results.
Get it quite quickly in the private sector. As an outpatient, while you're trying to arrange a bed. And if, for example, you think this patient, you're not sure, you do the CRP and it comes back as 2. And sets are like 94%. Patient's a bit anxious, so the tachycardia maybe from anxiety, maybe it's only like 100 per minute. You can say, okay, let's watch this person. But for the general practitioner, importantly, for that type of person who's going to be treated at home, you need to set up a home monitoring system where you'll be able to measure some changes in those patients, because that patient's condition can change. And typically, I'm sure many of the GPs will tell you, I don't know if there's anything typical about this condition, to be honest.
True.
I mean, it's like as Prof. Salim Abdul Karim said, it's like we're sailing the boat while we're trying to build it. So many patients, they tend to look okay and then sort of worsen around day 8. So you then want to have some type of predictive, capability. You may want to do an X-ray, for example, in a patient where you, as a tiebreaker, is this patient likely to be someone who needs admission? Or obviously you don't want to waste resources and cost the patient an arm and a leg, but you need to then, especially with the patient, you need a tiebreaker. If the patient is clearly well, very stable, no comorbidities, you would monitor and probably send them home. But if a patient is clearly sick, you would send them to the hospital. It's those that are in between, where you're trying to make sure that you're not wasting beds for patients who really need them, but you need some more information to make a decision. And so I think that's very important for general practitioners. That particular.
So any other points you'd add on to that?
Well, I think the initial assessment and then the monitoring is very important. And then I think the second thing which GPs are going to see a lot of is people who've had COVID-19 and are still sick. Like a week later, 2 weeks later, 3 weeks later, sometimes 3 months later. There's quite a lot of data coming out from Europe and Italy and even China, where the disease is a few months ahead of us, where many of those patients have persistent symptoms. In one study released from JAMA as a letter, scientific letter, last week, looking at patients from Italy who were followed up on average of 60 days later, 82% of them still had some type of persistent symptom, and some of the symptoms were pretty debilitating: ongoing muscle pain, ongoing joint pain, some of them had ongoing shortness of breath. So I think those will be expected. We don't know how to manage them yet, and we still don't know what will happen in 6 months' time or a year's time. But those are things which GPs would have to expect as patients come back with ongoing symptoms.
If I may ask quickly about TB, I mean, in our settings, you talked about chest X-rays as a tiebreaker, but given our comorbidities, do you think TB is an important consideration in our looking at these patients with COVID? What would be the dynamics around it?
I think certainly in patients who have HIV disease, we know that X-rays, TB X-rays can be far from typical and can look very different. Obviously, there seems to be no increased risk in patients who have controlled viral loads and have reconstituted immune systems. So you would expect those patients not to be getting TB. But given the high prevalence of TB in our population, it would be in your differential. But I think if that patient has got significant changes on their X-ray and using it as a tiebreaker, you would probably err on the side of admitting them to have further investigations, rather than waiting for them to be at death's door and then you can't find a bed. So I think those are the type of things you're going to have to be pragmatic in terms of the decisions you make when it comes to admissions. There are lots of algorithms out there.
Would you be able to share? I'm sure if you can share simple algorithms, I think just so that people in the audience could get it on the website later.
Screen sharing, I can share one that I've got.
Okay, do you want to share that quickly? I'm going to come back to you later. Shall we do that a little bit later? I want to ask you the question about the IMA broadly, and maybe we'll deal with that. That clinical algorithm. Let me just make sure that everyone gets a chance to speak. I think I want to ask Fathima Lambat as an intensivist. Shoaib just talked about now the challenge and where hospitals are closed, what we can do as GPs. But you're doing work in terms of supporting the community, enabling the community to do home-based case, management of this, almost ICU management, as you've mentioned before. Tell us a little bit about what that is and what you're doing in that project and how it's come together in a few minutes. Fatima?
Okay. So a few minutes is a little time when it comes to the
I know it's brief, and I'm sure people they always say there should be more, but go ahead.
Yeah. So I didn't make a PowerPoint presentation, but I'll quickly go.
If you wish to share it, not a problem. I think if you think that'll help you, give me 2 seconds to just no, give me a sec.
Okay.
I'll just make you co-host, and then you can go ahead and share. You'll have it in a sec, and then you can use that if you wish to share. Sorry, Shoaib, we should have given you that chance as well. I'll just make you co-host as well. Go ahead, Fatima. I think you should be able to share if you've opened your document.
Let me see. There's my
You have to open your PowerPoint before you find it on share.
Okay. I opened it now. And
now
then
if you look on share, you'll see it.
Okay. Just give me a second. Okay. Share. I don't see it yet. Yeah, it's PowerPoint.
If you've opened it, it should be
screen and just go to it. That's another way of doing it. If you
what? Wait, share. Yeah. I'm coming now. Yeah, I got it there.
Okay, good. Go for it.
Okay.
Yep.
So as you can see, so I'm Dr. Fathima Lambat. I'm a specialist anesthesiologist. I also did my fellowship in ICU at Johannesburg Academic Hospital. So I'm helping the GPs here because we found that the current situation where the beds are, there's a rising number of infections, the hospital capacity, we already have a stressed healthcare system. So you can imagine with TB and HIV and the complications that we have in the country, and we don't have the resource for that. So now with Corona and COVID coming to our country, we have a stressed burden healthcare system being even more stressed. And that is why I've put a little bit of a mnemonic. So we say LV, fast, let go. So it's location, ventilation, fluids and feeds, analgesia, steroids, thromboprophylaxis, lung exercises, antibiotics, glucose control, other management, and bloods. So if you can see, where's our location? Our location is actually at home. And then there's a question of when do I visit the patient? Who should, because now firstly you need to try and get a hospital bed, but now we're in a situation where we're not getting a hospital bed. So the GPs are used to dealing with milder patients. So now it's very difficult. Who do I visit? Who don't I visit? Who can I video call? The increased risk of PPE. There is PPE guidelines that we have made as part of the IMA, which shows good home PPE guidelines. So that can be shared. So here's the assessment of a patient. You can have mild, moderate, and severe patients. So the mild patient symptomatic treatment and symptom follow-up that the GPs are afraid with. The moderate to severe, hospital. However, as I showed you, hurricane, no entry to hospitals. So this is what Shoyab was alluding to. However, I've changed it a little bit from the NICD guidelines because I don't agree 100% with them. So mental status, I agree. If there's an altered mental status, it's moderate to severe. Severe would be altered mental status. If the sets are 85 to 92, it's moderate, but if it's less than 85, it's severe. The respiratory rate less than 25 or greater than 25, severe is greater. Heart rate, I've dropped it from the NICD guidelines because for a patient to get a heart rate of 120 takes a lot. So that is why I've dropped it to about 110. So if the patient is severe, it will be more than 110. Moderate will be 100 to 110. Hydration, easy from home to look at capillary refill time. So if the capillary refill time, so you can video call your patient, you ask them to press on their nails for 2 seconds or so, 3 seconds, and then you tell them to release and you see how your capillary refills. And if it refills 2 to 3 seconds, it's moderate. If it refills more than 3 seconds, it's severe. And then you can assess dehydration. So in the severe cases, you might need to PPE and go and assess the patient yourself, might need to put up an IV line, might need to give a bolus of fluids. So that's important. Temperature, if it's less than 38, it's moderate. 38 to 39, it's severe. However, the mild patients can get a high temperature of 39, which will resolve with antipyretics and anti-inflammatories. Blood pressure is important. I don't see a lot of hemodynamic instability in these patients. And I'll just go quicker because I know there's lots of other people that are going to
and we'll come back to some of this, so it's fine if you can just skip through some of the ones that you think are pretty evident. No problem.
Right.
Carry on.
Okay, so with ventilation, it's home-based, so you're going to toss between nasal prong, face mask, polymask, continuous positive airway pressure. It's difficult to make set protocols, but initially you try the lung exercises first. Then you try, if it doesn't improve, you try nasal prongs at 2 liters per minute and go up to 4 liters per minute. Face mask, if the sets don't improve with the nasal prongs and it comes in 40% or 60%, however, you need an increased flow rate. And our oxygen concentrators can come in 5 liters or 10 liters. So the 5 liters, the nasal prongs is okay, but the 10 liters we need for face masks or non-rebreather masks. So non-rebreather masks are also called polymasks, can use at 10 liters per minute. And these, if patients require this in hospital, I usually put them on a high flow nasal cannula or a non-invasive mask. But at home, you may not have an option. So you may only put them on a polymask and tell them to do lung exercises. However, there is a CPAP, which is used for obstructive sleep apnea. And I've been using this for patients at home. It gives room air. However, we put it over a nasal cannula and it's a tight fit like this. And it's shown to actually work with the lung exercises. The earlier you start on oxygen and lung exercises, the more effective the intervention actually. So feeding and fluids, these patients get very sick, very dehydrated. So we need to look at the capillary refill time and tell them to drink at least 1 to 1.5 liters. Watch for the renal patient and cardiac patient. Rehydration solution is very good because they can drink a liter of it. It has plasma electrolytes, just like our electrolytes. And ensure Fraserburn shakes are very important, right? Analgesia is important, and I'm sure you guys know about the analgesia, either paracetamol alone or combinations. Brufen was controversial because of a theoretical effect on the renin-angiotensin-aldosterone system and the ACE. However, you remember the other side effects of Brufen, so I don't like Brufen or non-steroidals actually. Steroids. In terms of steroids, I had to put this slide in, and I want to the stuff in and I want to
don't worry about him. Carry on.
I want to tell the GPs that we have to call a specialist when we are trying to, when we want to start steroids, because the specialist will know when to start the steroids. It's so difficult for me to even put protocols for starting steroids because it's very individualized. And if we start it too early, then it drops the immune system and it can help fight, can help fight the virus, and patients get worse. And I've actually seen this here. Thromboprophylaxis, also consult a specialist. The best thing is for the patients to mobilize. And then there's controversies between anticoagulants, antiplatelets, and then between prophylaxis and therapeutic doses, right? Antiplatelets, the studies are still going on, especially with aspirin. I feel aspirin at high doses, even in cardiac patients, is detrimental. But if the patients are 75 to 81 milligrams, we can give them if they have comorbidities. If they're healthy patients, I don't think we should start aspirin. These are the different factor Xa inhibitors, but at home I would not use Clexane because it needs to be monitored. It affects the platelets. It's affected by renal function. So I would rather use rivaroxaban because it's not, it doesn't affect the platelets, doesn't need to be monitored, and it's not affected by the renal function. But that also with a specialist, I have to emphasize and say with a specialist. Lung exercises, prone position. Some patients don't like the prone position. So you can either tell them to sit or stand upright for 30 minutes every 2 hours. You can ask them to blow a balloon or blow water inside through a straw. You must test this here because Kitioni did explain 2 types of lungs, and he thought high and low compliance lungs. So some of the patients I've noticed, if they blow through the balloon or blow water through a straw, their sets drop. So then they can't continue. But however, if they blow through and their sets increase, then they must at least continue for 10 to 12 times per day. Antibiotics, this is a viral infection. Do not start antibiotics. And that's why I like to take bloods, because if the PCTs are high, then we know there is a secondary bacterial pneumonia. Chest x-rays, if you can get it and if you can see a consolidation, then you can start it. But other than that, if it's just COVID pneumonia, do not start antibiotics. Azithromycin, we use it in bacterial pneumonias for immunomodulation. So they tried to see if it has the same effect in COVID pneumonias, but there's no proven benefit. In fact, it prolongs the QT that you can get to SARS and arrhythmia. So that is why I do not like azithromycin if it doesn't work. Glucose control is important. Monitor the glucose at home. DKA management at home is going to, Dr. Fadal and myself want to write some guidelines, but ideally manage in a hospital setting, but I feel that there's going to be a point where we'll have to manage it at home. And then symptom control, like Dr. Fadal was saying, the physios do a good job, but I find that at home on day 3, day 4, they get this tight chest or wheezes. So I tell them to nebulize in an isolated, well-ventilated room away from everyone. If it's just a tight chest, I tell them to nebulize with saline. If they have wheezes, I tell them to nebulize with either Combivent or its generic Duolin. I tell them, remember, it does have side effects of palpitations or tremors. So if they do feel that, they can halve the dose. Steaming does well for the patient, especially with the congestion. And then BP control in patients who are hypertensive. These are the bloods I take, right, when at home. FTC, UNECRP, PCT, INR, PTT, cardiac enzymes, D-dimers, IL-6 plus minus. The reason why I don't take ferritin, LDH, all of the others, because CRP is going to guide me. I've realized that in the beginning, we used to take the ferritin, we used to take the LDH at the hospital. I still take the LDH ferritin, but it doesn't change my management in terms of when I'm going to initiate steroids, when I'm going to initiate anticoagulations. So I don't really feel the need to take extra bloods, because here we have to be cost conscious as well. So that's about
Thank
it.
you, Fatima. I appreciate that. Jazakallah khair. Thank you. I think that, I think that slides will certainly be useful, and I think certainly people want to look at it. So I'm asking everyone if they've got slides to share it with me. But I think, Fatima, the purpose of the series is actually to look more at not so much the clinical challenges as necessarily as the priority, but the system issues. In other words, how is this working in getting GPs? We'll come back when Shoaib presents a little bit later about some of the issues you've raised. I'd love to ask a little bit more about the clinical, but for this discussion right now, how are private sector GPs and you pulling this off, and where is it succeeding and where is it not? And I mean, just in brief, if I may just, your little one's entertaining, it's great, everybody there is watching it, so don't worry about him. But just in case anybody missed something you said, if I were to just capture it briefly, essentially at home, we're looking at being able to manage this, the oxygenation of patients, where you are providing machines to patients, enabling them to address this gap or this difficulty between 85, 95, where we're sitting with a patient that you think may be managed at home, and where there's some leeway, where you're saying, okay, monitor and manage that oxygen, and otherwise you're looking at the controversies you've raised around steroids and anticoagulation. And otherwise, it's routine management of the patient clinically for their multimorbidity. So in sum, that's where it is. So tell us, how is that working on the ground?
So we're very lucky because in the beginning of the lockdown, we as a community got together, right? So we have a few specialists in the GPs, and my phone is always on. I'm always available. And there's a lot of GPs who first will ask for oxygen concentrators. We have 2 teams here. So I'll get hold of which GPs need the oxygen concentrators, and we'll support them via these 2 teams. And then a lot of GPs are in contact with me and will already tell me, this is the patient I have, this is the sets, this is how much of oxygen the patient is on. Do I need to start steroids? What do I need to do? So I will advise them. So it's actually working very well. In the week, in fact, today now, someone came to fetch a CPAP, which was donated. Thank you, Prof, for referring him to us. It's actually going so well. I've started someone on a CPAP with nasal cannulas, and he's actually off that CPAP. He started with me and a GP on steroids, on anticoagulation. He's off the CPAP. He's actually off the oxygen, and he's on his way to recovery. And the nice thing about home-based is we're catching them early. So it's not taking them time because they're reluctant to go to hospital. So when they have this option, we're catching them early, we're treating them early, and it looks like they're getting better early. Now we have another patient that we're starting the CPAP on. So it's actually working if you have a dedicated specialist with a good community of general practitioners. And that's what you need to network.
Yeah, no, of course. And I think that's a great project you're sharing. And I think it'd be interesting to see. Just quickly, you as an as intensivist working with how many GPs, and you said 2 teams that basically is managing equipment, plus minus
quite a lot of GPs.
10, 15, 20 more.
I'm just trying to go on our group. It's maybe about how many participants I say about 50 or so.
Oh, that's great. And
so that's why I'm busy the whole day.
Of course, more than one patient. So, and they're going to do home visits and managing from there. Great. Now, thank you very much, and Jazakallah khair. I think let me just move to, the question is that, this is great stuff that's happening in the private sector, but yet the private sector is not just sitting there doing stuff for itself. I want to ask, maybe, Essack can start. Essack Mitha, you can share a little bit about yourself, but Essack has actually been a private GP, but came along to a Johannesburg meeting of managers and clinicians where we clearly are battling in the public service to do some basic stuff. And I just want to get Essack sharing a little bit of his insight, and I think a little bit of the challenge between public and private and the contributions that are made. Just briefly, Essack, do you mind just telling people about yourself first, and a bit more, and then telling us more about that?
Thanks, Prof. It's an honor to be on this panel with such esteemed colleagues here. I was brought on board quite early on in this pandemic, and we attended a meeting at the Alexandra Community Health Center. And what was quite eye-opening for me at that time was how unprepared the facilities were to deal with testing a single patient. And a blueprint was laid out between the facility managers playing a part, but more especially the Department of Family Medicine at FITS spearheading this. And we created almost a blueprint of what would be needed in these public facilities in order to get them COVID ready. And this largely was setting up an area outside of the actual clinic where patients could be triaged, assessed, screened, whatever you want to call it. And those that might need to be actioned separately were taken to a separate area without them crossing paths with patients who would normally go into the clinic itself. The model started off with 5 clinics and was implemented quite well. And unfortunately, a lot of it was based on donations and contributions from private individuals, NGOs, and such. And it even involved cutting out stencils so that crosses could be marked on the floor, having 1 meter, 1.5 meter distance sticks to mark out your social distancing markers and things like that. So it was a lot of basic work, lots of like hardware supplies and things like that, tables, chairs, stationery, to the medical type equipment, pulse oximeters, thermometers, and things like that. And what has happened from there is that that model has been replicated in quite a few different clinics. And at the moment, I think all of the clinics in Soweto are almost geared up. And in lots of the regions in Johannesburg itself, there are public facilities that are able to cope or to manage patients that are coming through and get them sorted out. So that was the one initiative that took place. It was quite difficult to continually go back for donor support throughout all of this, but I think when your intention is clear, God opens the way, and we found that happening quite often. Even up till today, we continually get face shields, pulse oximeters, and things like that. So we've got a nice network of people who are able to receive and sort these items out and deliver to the clinics that need it. And then another project that we've actually embarked on closer to home, and pretty much taking what Dr. Lambert has been talking about, was the concept of community involvement, or the involvement of GPs in the community. So we've set up the 7 GPs that are available to assist the public, the general public in our area. And we are consulting. Most of them are doing telephonic and virtual consults, but we do have some that are doing physical consults as well. And we've also teamed up with an organization that is able to provide the oxygen concentrators and pulse oximeters. And we've got pharmacists on board who are able to deliver medications to the patient's house. So taking the lead from Dr. Lambert, there's Dr. Aisha Wadee in the Sunninghill Hospital, who's given us support, Dr. Ismail Ganshi as well, and the organization FMYO. We are actually able to take care of a lot of the patients in the Marlborough, Alexandra, Sandton, Sunninghill communities. And I think support like this from the different regional doctors would actually go a long way in this type of a pandemic.
So it's not only paying patients, you're referring to a sort of pro bono type work. Is this paying patients, or what is the nature of the project work you just mentioned? So
that is all pro bono work at the moment. So I know, I think it was 2 nights ago, the doctors were busy till I think about 11, 12 o'clock at night, you know, managing patients remotely where possible, making sure that they have their oximeters at least, keeping in touch with them, trying to get them beds in hospitals if they need it. So it's been a mixed bag. It's still early days for us. And I think we've realized that there's a little pocket of infection in the Marlborough area. So we are fielding a lot of calls, doing physical consults on these patients as well. And, you know, if there are patients that are on medical aid, great. If there are those that can't afford the oxygen concentrators, FMYO is able to donate it for a period of time. They take it back, they sanitize it, and make sure it's able to be used again. And Dr. Wadee is on that team as well. So it's quite a nice collaborative approach between specialists, GPs, NGOs, pharmacists, and a whole lot of other health personnel, paramedics as well, just to make sure that people that cannot get to the facilities that need to help them, cannot get a bed in hospital, are able to be looked after adequately.
No, wonderful. Alhamdulillah. I think that's great work that is being done. And Essack, really appreciate the support you've provided with all the people in the network you have to provide support to the public service of Johannesburg and the Department of Family Medicine, which I'm part of. I want to go to Fathima as the last person in our panel. I think we have, we were supposed to get a representative of IMA, but I think all the people here will be able to speak if including Shoaib. But Fathima Minty-Seedat, you've been very helpful to the public service as well, doing great stuff and involved in the Masks for All campaign. Do you want to share a little bit about what you've been doing, you know, besides Masks for All, but tell us about Masks for All and how that's worked. You're also leading a group in the Johannesburg area, which is interacting a fair amount with the public service as a private general practitioner. Assalamu alaikum. Fatima, go ahead. Fatima, I think you're muted. If I can just quickly unmute you. Yep, go ahead. Sorry.
Okay, assalamu alaikum. Hello to everybody.
Good, good. Go
Yes,
ahead,
so I'm a general practitioner from Lenasia, and I've been working in the area for approximately 18 years. I have a diploma in obs and gynae, so my practice is very female gynae based. Prof has been flooding us with emails for years. Sorry, Prof, I didn't read any of them. I just see your name popping up on my computer now and then, didn't have the time to read them.
Sure. No
and then you came and made a call for joining a group called Masks for All around April. And I think I joined 2 weeks after the group was formed. And then Dr. Salim Chunara asked me if I would coordinate Gauteng and try and get masks with the people in Gauteng. And I told him, no, it's just far too big. 15 million people are too much for me to handle. I settled for City of Johannesburg, and I became the coordinator for Masks for All in the City of Joburg area. So I then, on my personal capacity, started sending out messages to friends and family and saying, guys, give us some donations and funding, and let's get as many masks out. And I wrote up all these little cute things saying, I protect you, you protect me, my mask protects you, your mask protects me. Let's save some lives, Ubuntu, we can do it together. And fortunately, I got quite a bit of funding. And in that way, initially, we gave it out to a tailor and gave him a permit and said, so far some masks. From there, it went to CMT, and then they were producing masks for us. So we first had a CMT in Lenasia and then a CMT in Newcastle. And with all these masks and all these donations, we managed to give masks out to nearly all the public clinics in and around Johannesburg, ranging from Region A to Region G. So I've learned about maps and clinics, and I think I know more what's going on in the public clinics, and the public clinicians know what's going on there. And so that was one of the places where we've distributed a lot of masks. Then we also, in our Lenasia area, someone donated us 500 meters of a fabric called Spunbond, which we make masks out of. And this family made 5,000 to 6,000 masks, which were then distributed to the informal settlements around Lenasia. These masks were also donated to our SASA days and grant days in and around Lenasia. And we also managed to get hold of feeding schemes around Johannesburg, and some people contacted us and we contacted them, and the masks just went out and out and out until COVID finally surfaced. And then in the interim, we as a community said, so I was looking at Italy and UK and USA, and my biggest concerns were, when COVID comes to South Africa, what are we going to do? How are we going to manage this? And are we going to be digging graves like Italy and UK, and it very rife in the Indian community in the UK, and it was very concerning. But in March already, I personally bought an oxygen concentrator, put it in my garage, and I said, sorry, I like to say that the shit hits the fan, and my family needs oxygen, or my friends need oxygen. I have this machine. I don't know what to do with it, but I have it, and it's here. because I realized that if the private and the public sector are going to be flooded, even if I have a medical aid card, it's not going to be of any benefit to me or my family. And so I looked at this 15,000 investment, and I thought I bought this very expensive toy, and one day I'm going to put it in a museum and I'll never get to use it. But fortunately, we got to use it. I had my mother-in-law fell ill, and she's been on an oxygenator now for 3 weeks. So it actually came in very handy. But in all of this, we approached public health in Lenasia, and unfortunately, they couldn't help us or come to the party in that we were looking for a facility to set up oxygen concentrators. And our Lenasia South Hospital is currently under renovation. I'm not sure by now if they've achieved anything there. Initially, I know it was earmarked as a COVID-19 hospital, but then we were told that they have now moved to the idea of a district hospital, and so nothing was really happening. And another group of individuals in Lenasia started a team where they already started procuring oxygen concentrators and said that they would give it out to a small part of the Lenasia community. I've been friends with people who run ambulance services. So we have 2 ambulance services in Lenasia. I've been friends with the chaps who are in the field, the disaster management. So they called me when COVID just hit lands, and they said, we have an auntie whose husband is COVID positive. They've taken him to the hospital. The auntie's packing her bags and she wants to go to her mother's house now. What should we do? And the auntie refuses to test. And that's just, it was 2 days after Cyril said, we are now in a state of disaster. And I said, you know what, go now with a mobile nurse there and make sure the auntie, tell her if she doesn't let us do the test, we're calling the police, and that's how we're going to do the test. So I became popular with the disaster guys, because whenever they had a problem, they phoned me and said, what should we do with this patient? What should we do with that patient? And in extension 2, which is our less fortunate people, they actually called on me, and we the first families that had COVID, we gave out masks, 3 streets, 3 houses above, 3 houses below. So there was no stigmatization or discrimination there as to which house had COVID and who had COVID. And because with COVID, there's this big stigma and this big victimization. And it's like the way people think of COVID is a death sentence. And if you get COVID, you're going to die. And they don't realize it is a flu, but it's a deadly flu to certain individuals, like your high risk individuals. I'm sure you all know who they are, so I don't need to go through the list, as I've been doing this on radio for the last few months. And so then we all got together, the ambulance guys, the disaster guys, a few doctors, Fathima Lambat. We all had a meeting about a month ago. We met and we decided we're going to start raising funds, and alhamdulillah, we have now managed to we're in the process of procuring about 30 odd oxygen machines. Wow. So we're still looking for funding, because we don't feel 30 would be enough for the greater Lenasia and Lenasia South area. And because a patient could have it for a week, 2 weeks, 3 weeks. So there are limitations with oxygen concentrators, but it's at least you're saving 30 lives, or where the public sector or the private sector can accommodate these patients. So that's where we are right now. And I know there are lots of other communities who are doing some similar initiatives.
Yes.
And we're hoping to network with them. Yeah, we're hoping to network with them soon.
Yeah, in fact, out of this, when I circulated this, a whole lot of people started calling me and saying, can't we also be on this webinar and share our story? And I think that I said, we'll certainly get that chance and going forward. But I think that the key here is that there's a lot of networking, and I think building on that networking is quite useful. I think certainly for family physicians in departments of family medicine across the continent, is to look at what's going on between private sector and to engage with them, to perhaps liaise with them and share ideas, as we're trying to do now. So perhaps let me ask a very broad question to the full panel, and maybe Shoaib, you can lead that. IMAs, perhaps let's start with that. IMA is, an overarching Islamic medical association involving Muslim doctors. Do you think that it is a function of the IMA's work over the years that has built up this kind of, good networking? What do you think? Why do you think we've got such efforts emerging? And where's the role of IMA and maybe some of what IMA is doing nationally? Shoyab, you mind?
I think as you mentioned, IMA is sort of a body which is based on a religious ethic around delivering healthcare. That we aren't just doctors, but we're doctors which who subscribe to a religious ethic which demands of us a certain level of behavior, and that level of behavior would include helping to serve the public and serving people.
It's not just a private organization, not just private doctors.
No. It's doctors in the private and public sector. It's open to all medical professionals to subscribe to the tenets of the IMA, which are the founding tenets are to promote the practice of medicine which is consistent with the religious values of Islam. That means you would follow the Quran and the hadith of the Prophet ﷺ in terms of guiding principles ethically and morally. At the same time, we understand that as Muslim doctors and health professionals, there are certain particular rulings Islamically which may invalidate or make ethically difficult some types of treatments, for example, contraception, abortion, things which have come up, obviously kidney transplants, organ transplantation, which obviously need particular education and attention. So the IMA is linked with other Islamic medical associations around the world in something called the Federation of Islamic Medical Association, and linked up with other bodies, ethical bodies. So they're in existence for almost 40 years now. In fact, I think it will be 40 years this year. And they have an annual conference which gets doctors together and then discusses many of these issues, which include normal CPD issues, discussing standard management conditions, but also with some aspects of Islamic bioethics and so forth and so on.
And quickly, is there a presence of the IMA in Africa, or is it South African only?
So as part of the Federation of Islamic Medical Associations, there are about 7 African countries which have established Islamic medical associations, including Uganda, Kenya, Zimbabwe, and we've worked quite a bit with Zimbabwe in trying to support some of the initiatives, Sudan, Egypt, Tunisia. So there are countries which have got Islamic medical associations which have similar founding values and similar values in terms of promoting the practice of medicine in a particular way.
So I'll leave you to just put a link to the IMA South Africa. I'm sure it's got details. So if any person in an African country wants to link up with you, they would be able to do that. And I think that would be useful for any family physician in any public service to reach out to to your sort of counterparts anywhere. So let's just turn this conversation towards, what Fathima raised and I think has been raised. What has been the relationship between the public and the private sector? I mean, there seem to be some challenges. What's working, what's not working between the public and the private in terms of COVID responses, and some frankness about it.
I mean, as you know, the private-public sector divide is an unnatural and unhealthy divide which has developed over generations in South Africa, which has a number of root causes, ranging from the free market system to inadequacies in the public health sector, people, opportunism and so forth and so on. So there are many reasons why the public sector and the private sector are separate and have functioned as separate entities in this country. And obviously, they're reflective of the generalized inequality in South Africa, where the haves have a lot and the have-nots have very little. And the private sector is just one of the more obvious reflections of that inequality. Obviously, we're reaching a situation now where ethically it becomes untenable, and you can't have a situation where the majority of the population is susceptible and cannot access care, which is reserved for a small amount of the population based on economic realities. So there will have to be some type of convergence of the private and public sector. Maybe it will be an acceleration of what the government has realized, and obviously that's been dogged by multiple issues: mismanagement, political interference, corruption, and other things. There are many other reasons why that hasn't happened in the past. So the public sector, in terms of, I think the area where the private and public sector ironically overlaps the largest is at the general practice level and the primary care level. There are many patients, and I'm sure you know, who will access both public clinics and general practitioners.
Very much.
They will go to the general practitioner, get some advice, and then the general practitioner will say, I can't do much more. You need to go to the clinic to have blood tests, to have an x-ray, to have so forth and so on. And I think that interface has been the most functional interaction between the public and the private sector, albeit with problems. So, but I think this is an opportunity, particularly for general practitioners, to expand their ability to contribute to that partnership in a significant way. And I think aspects like home-based care, and which is really right up the alley of general practitioners, and it should be the way that medicine moves, not just for COVID-19, in terms of most medical conditions, which we can manage at home. And I think over time, with it's much used with the fourth industrial revolution, we will have systems which will enable us to do home-based monitoring and care, which will be much more fine-tuned and enhance our ability to treat patients away from these cesspools of microorganisms, which are hospitals. So I think if that's a benefit of COVID-19, it could be a benefit going forward into the future. One of the biggest problems at the moment has been getting private hospitals to accept patients from the public sector. In the Western Cape, in my understanding, Riyas can probably tell you much more because he's been involved in the sector. There have been a very few patients who have managed to cross that divide. And ostensibly, it's because the public sector and the private sector have not been overwhelmed. The Western Cape has been at great pains to say that they have not been overwhelmed. They've been able to accommodate everybody with their field hospitals and so forth and so on. But if we reach a situation in Gauteng, there are plans for public hospitals to transfer patients to private hospitals, maybe non-COVID patients, maybe less sick patients, and a variety of other patients to make space. And there's several parts of that argument which haven't been worked out. Who gets paid? How do they get paid?
Yeah, it's challenging.
And you send mostly COVID patients, you send non-COVID patients. So, and then obviously I think one of the things we mustn't lose sight of in this COVID epidemic is that we can't prioritize COVID positive patients over non-COVID positive patients. You can die just as easily from TB, you mentioned, or from a non-COVID pneumonia, or from malaria when we hit summer, and then COVID. So if we really focus all out on COVID and focus so deeply, we may take our eye off the big picture. And certainly we'll have to have an alliance between the private and public sector to make sure that that's done.
Well, thank you for that. I think that's very useful. And let me turn to Riyas. You pointed him out. Riyas, if you were to look at COVID, and I think Shoaib's intimated it, but let me ask a specific question. How is COVID reshaping the terrain for NHI and universal coverage, which brings the public and private sector together? What are your thoughts about what the future looks like? Have we moved into a new paradigm? Are we actually going to get something serious happening that's going to shift the sands? And has COVID contributed to it?
Yeah, I think it's a very difficult question. I think there's always going to be anxiety around the nationalization of private facilities. We understand that there's a private and a public sector, but the private sector in South Africa is a duplicate system. It's a system where people self-fund themselves in addition to giving their own VAT and voluntary contributions to the public sector. COVID in itself is a stark reality because it demonstrates to us the inequality in our country, where a large population has to access limited beds compared to a population that's employed it as medical insurance, a duplicate insurance, and where the patient to bed ratios are less. What's happened with the advent of COVID is that there's been a generalized acceptance that this is going to be an issue already from March. All stakeholders have come together with National Department of Health, private sector, the laboratories. People have come together and are sitting together and talking. They're talking about how can we help each other. We know that there's already been discussions between private sector and public sector and at the national level to talk about how can we use private sector beds to house and to provide services to public sector patients. It's a very difficult conversation because you have to talk about tariffs and how do you pay for that services, but those conversations are happening. And I think in the coming weeks, we will see that this will, you'll actually see public sector patients in private facilities. We're seeing it in some of the, at one in Western Cape and Eastern Cape already. And we'll see more of it in Gauteng in the coming weeks. I think that's the foundations for for public-private partnerships.
Yeah, and it's something that I think that, you know, as Muslim doctors, as the IMA goes, ought to be highlighting. How are we starting to think post-COVID? How are we thinking out of this, out of the box, and you know, give some direction? Thank you, Riyas. I just want to turn to Essack about a question that's been posed. I think, Essack, you mentioned, you've actually responded to it, but you may ask a question about GPs using video and IT in their consulting. Has telemedicine, telehealth also had a substantial effect in the private sector? In the public service, we just don't seem to have the capacity, but what's happening in the private?
Well, I think what COVID has done is it actually forced us to go down an avenue that we were probably resistant to go down. The concept of telephone consulting has been around for a couple of months. I know Discovery had a project where there's virtual consultations that are able to be conducted in the private sector. I think what has happened over here is a combination of the fear factor that has been raised through COVID, both from the health practitioner side as well as from the patient side. And then obviously your moral and ethical guidance in dealing with patients and trying to provide the best assistance that you can. So seeing a patient and managing them remotely instead of seeing them physically in your rooms every day or every 2 days has presented a great opportunity that seems to be taking off quite well. At the moment, there's lots of telephone calls, WhatsApp messages, pictures of pulse oximeters, videos of oxygen concentrators, those types of things that are being sent through to the doctors on our group. Even in terms of teaching doctors who are not used to setting up these oxygen concentrators, we're actually in the process of setting up a video now to show them how to actually do this. So utilizing the internet and WhatsApp is a powerful resource that can be used very effectively in situations like this.
Are there any, software out there? Are people using anything in the market in South Africa? If you know of any of EHRs with telemedicine, telehealth, is there a serious presence?
Discovery had introduced one where patients could actually log onto their system. I think it's Discovery Patients. Log onto the system, type in what their symptoms are, and have a medical practitioner respond. I followed that for a couple of months, and a lot of times it was something related to you need to come in and see your doctor, kind of a thing. So it's not easy to manage something like that. I think in somebody's own practice, it's a lot easier to communicate with your patients. And like Shoaib said, it might be the way to go forward in dealing with patients with chronic diseases, where you can tell them, right, you don't need to come and see me every month or every 2 months. Here's the equipment that you need. Use it at home. Send me the screenshots. Let's chat via telephone or by video call. And that would solve a lot of issues, I think.
No, thank you, Essack. I think we'll try and close in the next 5 minutes, just to kind of bring up some of the other questions that have been raised. That question was from Oliver van Heck, but he's left. Musa Dessa asked the question about litigation. I think it might be something that was aimed at what you're doing, Fatima, in the community. How do you manage that? Is there not a possibility with home-based ICU kind of care that patients might litigate the GP that's doing that? Do you want to share a little bit on that? Fatima, you are muted. If you can just unmute.
Okay, so that is a problem, and especially with MPS and especially with MPS. So the GP and me, we have a consent form and everything, especially with the one I work with in Lenasia South. And in that consent form, it has all the complications and that of the steroids and the rivaroxaban or whatever we use. And there's a disclaimer there as well. So you have to be very careful as well. But it's such a balance because you're trying to help humanitarian wise, and then there's a medical legal implication. So that is a problem. I did speak to a lawyer before I even initiated anything, and then we got advice from them as well. So
in fact, Essack mentioned a sort of disclaimer of sorts that they've set up in their project.
Yeah.
Okay. Okay, and then I think, you know, there are, I mean, this question, Fatima, maybe we can close on that, you know, Fathima Minty, about the question you raised about attitudes amongst patients. Fathima Minty, if you don't mind coming on, then we close on that. I think it was the question of, you know, the attitudes of patients. How are people responding to masks for all and the messaging that was previously there? You were a practicing GP. How are they relating as to you as a private doctor, giving that messaging, and how is it now shifting? You mentioned stigma, but what's going on now in terms of patients and the education levels on the COVID now? You know, where everybody's kind of worried sick. What do you think's going on? Tell us about what your sense of the community is like.
So initially, COVID was more of a conspiracy theory, is that's what a lot of people told us, and they just didn't want to listen to us. So we'd say wear a mask, and you know, why should I wear a mask? And mask is going to give me breathing problems, and people came up with lots and lots of different stories. And Prof, I'm sure you know, through our coordinating team, all the challenges we had trying to put out all these little fires about mask usage and the correct usage of masks and the social distancing. So as a GP, I've been on a few different radio stations singing the songs of, you know, precautions, basic precautions, social distancing, hand washing, wear a mask. And initially it took a very long time to take off. Now that people are seeing the rise in the numbers, and when also retail sector came in and said, yes, you can't enter a shopping center if you don't have a mask, that's when things started taking a bit of a shift, and people now had to have a mask if they needed to get on a taxi or go to a shopping mall.
There was a change out of the campaign, and a whole lot of other people talking about masks for all, and government shifted from saying, no, don't worry about masks, to now everybody must wear masks. I think at the end of April, somewhere there, that shift occurred, which made a big difference. So do you think that with that national decision, everybody must wear a mask, do you think people are actually taking it seriously now? And where are we with the COVID understanding of COVID and the challenge we have around us? I still see challenges around us in terms of behavior.
There's still a lot of change. There's still a lot of problems. Let's put it that way. You know, lockdown, people ask, was lockdown necessary? Did lockdown serve any purpose? Did we achieve anything out of lockdown? Maybe if I look back, I say things should have been done a bit differently, because, you know, societies just carry on doing what societies want to do. And the reason we see why we're having spikes in, say, an Indian community is that, you know, it's the type of culture we live by. And so when somebody dies, everybody wants to be there. And everyone wants to attend funerals. And when somebody gets married, everybody wants to be there. So for telling an Indian family that only 50 people can attend a funeral or a wedding is not happening. And I think the other problem that came in is lockdown went on for very long. And so people felt, they started having mental health issues where they felt excluded and they felt they were bogged down in their houses. So when we came into level 3, people all of a sudden thought they had this freedom to now go where they want and do what they want, but they didn't realize that the last 2 months should have actually trained all of us to learn. Basically, if we did anything in the 2 months was to learn what we as individuals should do when we go out in society. And sometimes I see people now wearing masks that weren't wearing masks before, because now they're seeing all these deaths around them, and the fear factor is now coming in, where they're petrified because in every family now there are deaths. There's nobody who knows nobody who haven't lost family members or friends or the neighbor or someone down the road. And I think now we're dealing with fear factor, and I'm hoping society will do what they're supposed to do. Unfortunately, in every community, there's always be people who still say it's a conspiracy theory and there's nothing like COVID. But I think as time progresses, hopefully they'll get some insight into that this is a problematic disease.
Well, thank you very much. Unfortunately, we don't have too much time. I know that Shabir, Bamji, and Musa Desa have put up their hand, and unfortunately, we're going to have to, stop it here. It's really been very helpful. Shukran, Jazakallah khair to all of you for participating and providing your insights. I think the message out there is simple, that there's lots of things happening in the private sector, and there's great opportunity for all of us in public and private to come together around COVID and to be able to see if we can make a real difference. Unfortunately, it's very testing times. I think it may shift the sands and create a new post-COVID society. I think the challenge will be how deep a difficulty we have to go through, how deep a challenge we have to go through. And I think, like Fatima just said, behaviors may only change and COVID may only be controlled when we know someone who has died, an unfortunate fact. But I think that hopefully that results in change of behavior and stops this COVID rise and flattens it out. So to all our listeners, all 45 people who've attended, thank you very much. We really appreciate you attending. And please remember that we have this weekly webinar every Friday at in the afternoon. Please join us next week. We will certainly be trying to get another very interesting space in South African primary health care to share and see what goes on and what wonderful work our amazing healthcare workers are doing. So to all of you, Assalamu alaikum, and enjoy your evening. Please keep safe.